So maybe one way to look at this would be, let's talk about what those options are, and is there data available frontline for patients with the deletion 17p? That may be the best way to try to decide how to select.
Sure. So in the first patient we discussed, we talked a lot about ibrutinib-based therapy, which can apply for this patient as well. But we didn't get a chance to touch on the other treatment options. So obviously, one of the very appealing treatment options that really recently emerged is venetoclax-based therapy. So in contrast to ibrutinib, which is a continuous treatment, venetoclax treatment has been shown that you can use it as a time-limited therapy. So the frontline data came from the CLL14 study, which is comparing, again, they're choosing the chlorambucil plus obinutuzumab as the control arm, and the experimental arm is the venetoclax plus obinutuzumab. So in this arm, patients were actually treated with obinutuzumab for the first 6 months. The first cycle is a lead-in with the obinutuzumab alone to debulk the tumor in order to reduce the risk of tumor lysis associated with the venetoclax. So venetoclax is introduced after the first 3 weeks of treatment, and then a patient will go through the standard 5-week dose ramp-up to go up to 400 milligrams and continue the treatment for a total of 12 months. So it's a 12-month treatment, and all patients will stop treatment at that point. So 1-to-1 randomization for 432 patients total. The median age of the patient is 72 for the venetoclax obinutuzumab arm and 78 for the chlorambucil obinutuzumab arm. Most patients have some comorbid conditions. The primary endpoint is progression-free survival. So in this study, it has demonstrated that venetoclax plus obinutuzumab has a significantly longer progression-free survival compared to chlorambucil obinutuzumab with a hazard ratio of 0.33. And the most striking thing is to looking at the response rate. So you can see that the venetoclax plus obinutuzumab actually has a very high overall response rate of 85%, but also the complete response rate is almost 50%. And that's compared to only 23% with the chlorambucil obinutuzumab combination. But the most important data comes from the MRD, or minimal residual disease. So MRD in this study is defined by flow cytometry for less than 10 to the minus 4 cells detectable, either in the peripheral blood or in the bone marrow. So in the peripheral blood, the MRD negative rate in the venetoclax obinutuzumab combination is actually as high as 76%. In the bone marrow, the MRD negative rate is 57%, as compared to 17% on the chlorambucil-based arm. So we know that with the ibrutinib-based treatment, it's very difficult to achieve even a complete response. To achieve an MRD negative response is almost nearly impossible, very, very rare. But apparently with the venetoclax-based therapy, you're really able to achieve this very deep response, and probably that's why a patient can stop treatment and remain in remission for quite a long time.